my disclosures. So the background is that meniscus allograft transplantation has issues with availability, sizing, and it's also expensive. Furthermore, there have been some previous studies looking at autograft tendons as meniscus substitution. Already in 1993, Dieter Kohn presented in Keista an animal model where he used patella tendon, and later on a patient series using quadriceps tendon. But there are no real data what happened to those patients afterwards. Some 20 years ago, Johnson and Fegan presented 5 patients who were on a waiting list for total knee replacement, and they did lateral meniscus substitution using 4 CMIT, single-stranded, and 1 patella tendon, but all failed. But that's maybe not so strange, since they all were on a waiting list for total knee and had severe OA. A couple of years ago, Melanin reported 2 cases where he used the peroneus longus for lateral transplant with a short follow-up, and the results were okay. The hypothesis for this study is that the semitendinosus tendon could function as a meniscal transplant after total meniscectomy. And we had ethical permission from the Regional Ethics Committee at the Karolinska Institute in Stockholm, Sweden. The inclusion criteria was age 20 to 50 years, subtotal or total meniscectomy, and they should all have post-meniscectomy symptoms such as pain accelerated with activity or weight bearing. They shouldn't have any OA, and Albeck 0 was supposed to be graded in all these patients. Alignment, they should be well aligned, hip-knee angle plus minus 3 degrees, and no persistent ligament insufficiency. And if they had an ACL instability, we performed an ACL reconstruction or revision. We evaluated the patients with clinical exam, MRI and plain x-rays, as well as PROMs, Coos, Lysholm, Tegner Activity Score, and Global Rating Score, 0 to 10, where 0 is bad function and 10 is excellent function. The technique I used was harvesting a CMIT tendon. I folded it double, and I had a running suture along the double folded tendon, and then pull-out sutures at both ends. And I formed it as a meniscus-shaped transplant. Then it was inserted into the knee with arthroscopic technique, similar to MAT fixation of a soft tissue meniscus transplant with bone tunnels and sutured with all inside in the back, inside out in the mid portion, and outside in sutures in the anterior horn. Before we started with the patient cases, we did cadaver testing, and this is a cadaver where you can see on the right the meniscus substitution is sutured in place. The rehab was similar to meniscus allograft transplantation with partial weight bearing 6 weeks, hinged brace for 6 weeks. It gradually opened over time. Looking at the demographics, you can see that the first 7 patients were 6 females and 1 male, and most of them were medial, 1 lateral at patient number 7. And this lateral case, he had a 6 degrees of varus, which was sort of favorable for him. And the other ones had maximum 3 degrees of varus for the medial transplant. I have actually done 2 more cases now, just the last 3 weeks, 1 medial and lateral. And as you can see, most of these cases had an ACL reconstruction performed before, which had failed. So in most cases, I actually did a revision ACL reconstruction at the same time as the meniscus transplant. And in these 2 last cases, I've performed now the last 3 weeks. There has been one with ACL revision, a medial, and then one lateral isolated meniscus substitution. So the results. This is patient number 1, where you can see the graft in place to the right. And you can see that I've used this so-called hay bale technique when I suture. So I sutured around the meniscus to the capsule. And the idea is that the weight and the weight bearing itself will form this transplant to become more wedge-shaped like a normal meniscus. And this is an example of a patient number 5 with an MRI after 5 months. And you can see to the left that it's sort of wedge-shaped meniscus on the sagittal view. And you can see the bone tunnel for the posterior root on the picture to the right. Another patient was re-arthroscoped after 6 months due to some extension deficit. She was also ACL revised at the same time as the meniscus substitution, and we removed some scar tissue, but then we could actually also examine the new meniscus. And as you can see, there were capillary ingrowth and synovial coverage of the transplant, and it was sort of wedge-shaped when you looked into the knee. The KOOS results for 12-month follow-up, as you can see here, most of them improved, and as a group, you can see that there was a significant improvement from pre-operative values to 12-month values. Looking at the global score, you can appreciate that of these first 7 patients, 5 were significantly improved after 12 months, and after 24 months, so far only 6 patients have been followed up, and you can see that at least 2/3 have been significantly improved after this procedure. And they were also improved in terms of Lysholm score. So in conclusion, autologous semitendinosus tendon could potentially be an option for meniscus substitution in selected cases. And graft survival is promising at 12 and 24 months, but patient selection is very important, and beware of too much OA and high BMI. And the 2 failures that we had in this series were actually too much OA in one case and high BMI in the other case. And finally, we concluded that so far, about 2/3 of these cases that I've done have been significantly improved over 2 years. But this obviously has to be continued, and we will see what happens to the next few patients coming up. And I would like to take the opportunity to invite you all to the 20th ESCA Congress now in Paris to meet the spring. It's a face-to-face congress, and it's the first face-to-face congress after the pandemic. Full of lectures, world-class scientific program. Very warm welcome to Paris in April. Thank you. Bye-bye.